Today I'm here to discuss my literature review into the question, is ginger effective in treating chemotherapy-induced nausea? What is chemotherapy-induced nausea? Well, it is the most concerning and anticipated side effect of the treatment. It affects up to 80% of patients and it can affect their quality of life and may even affect their treatment outcomes. And it also puts pressure back onto the healthcare system. There are three types. The first is acute, which occurs in the first 24 hours after the commencement of treatment. Then there's delayed, which is more than 24 hours after the commencement and can last up to several days. And anticipatory, which is in the lead up to treatment commencing and is often experienced by people who have had nausea in previous chemotherapy rounds. So we're looking at ginger in treating nausea. It's otherwise known as zingiber officinale. It's been used for thousands of years in traditional medicine. Ayurvedic medicine referred to it as the universal medicine, with many healing properties, including in the respiratory and digestive systems. So I had some inclusion criteria for my studies. They were ginger or zingiber officinale in any form, all conducted in the last 10 years. Patients over the age of 18 undergoing chemotherapy for any cancer type, English language, and all peer-reviewed. So I had 5 studies that I critiqued. They were all published between 2008 and 2016. 3 studies were randomised controlled trials. 4 studies showed benefits of ginger. 1 showed no benefit in any phase. Of the randomised controlled trials, you can see we had 2 showing benefits in the acute phase and 1 showed no benefits in either acute or delayed. So limitations. So despite the optimistic results, I didn't think the findings are solid. There are a number of limitations that I think need to be addressed and maybe considered in future studies. These included the emetogenicity and use of antiemetics, the dosage and type of ginger used, and even the recording scales used by patients to record their nausea levels. So population sizes. 4 trials had small populations ranging from 28 to 78 participants, and these were determined based on predictions of what they thought the number they needed to achieve a statistical significance. However, one study conducted by Osler and Özdemir varied their sample size, where it started with 60 and dropped down to 34 in subsequent rounds of chemotherapy. This was way below what was considered to be an acceptable level when they determined their acceptable sample sizes. So they went on to show a positive effect of ginger to placebo in both acute and delayed phases, but the drop in sample sizes raised some questions to the reliability. There was one trial that had 576 participants and showed positive outcomes for ginger. However, there are a number of other limitations to this study that questions the findings, even though it was a larger scale. So antiemetics were used in addition to ginger in all studies. However, I don't believe there was enough consideration of the dosage and the frequency in how much the patients were using these. I think there really needs to be more accountability of this to understand the effects of it reducing the nausea. In addition to this, the Ryan 2012 study used a different type of antiemetic. It was a 5-HT3 receptor. All patients were given this on day 1. There was a claim that the receptor is more effective against vomiting. However, the most favourable results were in this study in the acute stage. And so what was the true impact of this receptor? So I think with insufficient measurement of the antiemetics, it brings uncertainty to the results across all studies. The emetogenicity is also important. In all the studies, they range from intermediate to high with varied results. So, for example, in the Panahi scale in 2012, the regimes range from intermediate to high, and they had a decreased prevalence of nausea in the acute phase. The Themlicotrol in 2016 study, however, a homogeneous group of breast cancer patients all on high regimes, and they showed no change in either acute or delayed phases. In addition to that, there was a change in the regimes in 35% of patients due to adverse effects, but there was no recording of the impact of this change. So what was this impact? And the Levine 2008 and Ryan 2012 study did not report chemotherapy regimes at all. So I think more consideration of this needs to be given to validate the outcomes. Ryan in 2012 commenced their treatment 3 days prior to chemotherapy starting. So their results were most favourable in the acute stage, but weaker in the delayed stage. So was this because they started 3 days earlier, or was it because of the use of the 3-HT receptor? So I think more trials commencing dosage prior to treatment are needed to see whether these positive results continue. So the dosage in ginger form varied amongst the studies. Ryan in particular was very different. He used a liquid concentrated, used a liquid concentrated form of ginger, ranging from 0.5 gram to 1.5 gram per day. And the biggest income was 0.5 grams with a 0.017 p-value and 1 gram. The 1.5 did not show a significant reduction at all. In comparison, all the other studies used dry ginger, and of the two that showed their measurement of 1 gram, Thamlicatical showed no impact and Usland had positive results. So more trials required to determine optimal dosage and even what is the best form of ginger. Ginger and protein. Levine's study had many limitations, bringing uncertainty to the results. It was compared effects of ginger in conjunction with a high protein diet. It focus seemed to be more on protein than the ginger. The placebo meal did not contain any ginger. Positive results in the delayed phase, but there was a lack of understanding of the effects of just the ginger alone. So this, with a lack of blindness, where the patients were aware of treatment, brings a lot of questions to the results in this study. The recording symptoms varied across the studies. In the Thamlicatical one, for example, they used a really large scale of 0 to 100, where I think a scale this size could be limiting due to its broad nature, where Aslan and Ozdemir used a smaller scale of 0 to 10, which I would believe would be more accurate for recording nausea symptoms. So maybe future trials should consider the different scales of nausea recording. So for my conclusion, even though the current findings are optimistic, I think they're a great basis for further trials. However, important considerations in future trials need to be the consistent sample sizes, effective antiemetics on nausea, effects of the treatment regimes, different dosages and forms of ginger, and the scales to record the nausea levels. Also, trials commencing dosage prior to treatment day I think would be beneficial. So for clinical use, I think even though the current results look promising and there's no serious adverse effects of ginger, more trials considering the limitations are needed before ginger can be established in a clinical setting. So thank you for listening, and I hope you have a good day. Thank you. Bye-bye.